Okay, we're going to get started. Good afternoon. My name is Bill Burns-Lynch, and I'd like to welcome everyone to today's webinar on Jumpstarting Community Inclusion, Building a New Organizational Capacity. This webinar is being delivered today by the Temple University Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities. And I'm going to ask if we could get our slides up. Thanks. And we can go to the next slide. So the presenters today are all affiliated with the collaborative, and with us we have Dr. Mark Salzer, Center Director and Professor and Chair of Rehabilitation Sciences at Temple University College of Public Health, Richard Barron, Co-Director of Knowledge Translation for the Temple University RRTC on Community Living and Participation of Individuals with Psychiatric Disabilities, Dr. Gretchen Sneathan, Center Assistant Director and Assistant Professor of Rehabilitation Sciences at Temple University College of Public Health, and Bill Burns-Lynch, Director of the Temple University Collaborative Consultation Services. Before we begin, I have just a couple of quick housekeeping details. First, the webinar is being recorded today and will be available for viewing within the next week. We will be forwarding you the link along with an evaluation survey next week and would appreciate your taking the time to respond to the survey with your feedback. After that, the webinar will be available on our website, tucollaborative.org. Second, as attendees today, your audio will be muted throughout the entirety of the webinar. If you are having any technical problems, you can send us a message through the chat function or send our technical coordinator, Jared Pryor, an email at jaredp@temple.edu, and that's jaredp@temple.edu. And finally, we're scheduled to go till 3 p.m., and we will adhere closely to that time frame. To that end, we hope to have time available before the hour is up to answer questions. When we get to the Q&A portion of the webinar, you'll be invited to share your questions via the chat function in WebEx. Okay, next slide. Here's what our agenda looks like today. First, we'll provide a quick overview of the Temple University Collaborative, followed by a brief look at our research activities. We'll spend some time defining community inclusion, and then review 10 key strategies for building organizational capacity. And finally, hopefully, we'll have some time to follow all that up with some questions and answers. And with that, I want to introduce our first speaker today, Dr. Mark Salzer. Mark?
Thank you, Bill. Jared, next slide, please. It's great to have all of you join us today to talk about some of the work we've been doing for more than 12 years now. We are, as Bill mentioned, the Temple University Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities. We have two key missions. One is to advance knowledge through rigorous research aimed at developing practical technologies for maximizing community living and participation of individuals with psychiatric disabilities. Over the years, we've published more than 200 research studies pertaining to community inclusion and community participation, and we're very excited to share that information with you at some point, including mentioning some of that research in today's presentation. We also work very closely with consumers and other key stakeholders to make sure that our research findings don't just sit in academic journals and actually make their way into national, regional, and local policies, programs, and practices. This is a key function of what our center is all about, and we're really excited to be able to work with any of you in the future in any of the areas that we talk about today. Our center, our collaborative, does receive funding for a rehabilitation research and training center from the National Institute on Disability, Independent Living, and Rehabilitation Research, formerly known as NIDER within the Department of Education. Now it's within the Federal Department of Health and Human Services. And we've been doing this type of work since 2003. So we have a significant amount of experience both with research and making this research become applied in policies, programs, and practices. Next slide, Jared. Our research is really focused on promoting community inclusion and community participation, and the rationale for this really comes from some research that has been conducted, or really census tracking of people with serious mental illnesses who have historically been institutionalized and more recently have moved into the community. This table actually presents some data showing that in 1969, there were approximately 370,000 people who were institutionalized in state and county hospitals, psychiatric hospitals. And in 2011, which is the last year that we're presenting here, there were approximately 41,000 people who were institutionalized. So there's been a significant decrease in the number of people living in state or being hospitalized in state and county institutions, which is a good thing. But, Jared, next slide. But our research has shown that people are not fully participating in the community like everyone else. Our center over the last 12 years has conducted ample research in these areas. We've demonstrated that people are living in segregated parts of the community where they're exposed to high levels of crime, substance use, high levels of unemployment in the neighborhoods where they're living, significant breakdown in the type of housing, the physical structures of the housing in the surrounding neighborhoods. We've demonstrated that people have lower educational attainment than the general population. There's ample research showing that the employment of people who experience mental health issues is lower than the general population. This leads to a great deal of financial dependence on Social Security, both SSI and SSDI, where people at most, depending on your location, maybe obtain about $1,000 a month, which is associated with poverty, which has a great impact on the community inclusion and lives of people who experience mental health issues. We know that people have very limited social roles, not just as students or as employees, but also social relationships with others. People are impacted in terms of their parenting, their relationships with siblings, and their friendships. People have smaller social networks than the general population and have social networks that are predominantly occupied by providers in the mental health system. So limited social roles. We know that people are less physically active and are engaged in fewer leisure and recreational activities than they would like. There's limited attention to spiritual issues and mental health programs, and people are interested in being more engaged in religious and spiritual activities. And we know that people with mental health issues in the system feel like they have limited opportunities for self-determination and empowerment. So really the rationale for our center and why we think our work is so important is that, again, there are more people with mental health issues who are living in the community, but they're not fully participating in the community like everyone else. Next slide, Jared. The definition that really drives a lot of our work around community integration is that it refers to the opportunity to live in the community and be valued for one's uniquenesses and abilities like everyone else. This is a definition that's really based on the Americans with Disabilities Act in 1990, and I can't go into these in a lot of detail, but the Supreme Court Olmstead decision in 1999, where the Supreme Court found that unnecessary institutionalization is a form of discrimination prohibited by the ADA. Community integration and the importance of community integration is also grounded in the President's New Freedom Initiative in 2001 and the President's New Freedom Commission report in 2003. The basic point that we like to make about community integration is it refers to, again, the opportunity to live in the community like everyone else, and that community integration is a right for people who experience psychiatric disabilities. Next slide, Jared. In our work, we've really been influenced pretty significantly by what's called the International Classification of Functioning Disability and Health. And this is a framework of that classification that was developed by the World Health Organization more than a decade ago. Unfortunately, we think that this is something that hasn't widely influenced U.S. healthcare yet, and one of our jobs is to really help people become more familiar with the International Classification of Functioning Disability and Health. And one reason for that is that this framework really helps us understand participation, and you see that in a red box on the right-hand side, participation as a key element of health. This framework talks about health in three different domains: body function and structure, which is how we typically think about health. That's a broken arm. That's problems with our pancreas or our liver. That's problems maybe with our brain, something like that. That's body function and structure, and that's typically what people think about when they think about health. But this framework also talks about health as involving specific activities as well. These would be things like grooming or being able to dress oneself or budgeting, those kinds of very specific tasks or actions. And the last aspect of health that the World Health Organization thinks is important is participation. And that's really what we're going to be talking about today, primarily, how we can promote participation to facilitate health, wellness, and recovery of people who experience mental health issues. Participation refers to involvement in a social situation. This means being a student, being an employee, being a parent, going to church, synagogue, or mosque, engaging in leisure recreational activities, voting, volunteering, living good in terms of housing. So really anything that involves social interactions and meaningful activities is what we're concerned about with our center, and what we think is critical to promoting community integration and community inclusion. You'll also see that I have an arrow pointing to environmental factors. The World Health Organization identified environmental barriers as having a major impact on the health of individuals, of all of us, including people with who experience psychiatric disabilities. And that's something that our center really has spent a lot of time doing research, trying to look at what these environmental barriers might look like, things like poverty, things like discrimination and prejudice, as well as the types of neighborhoods that people live in and who their social networks are, as major factors that affect the participation of people with psychiatric disabilities. I'm not able to go into this in a lot of detail, but I'm happy to talk with any of you at any point in time about how you can use this framework to really help funders and other people support your ability to focus on promoting community participation of individuals you're supporting. Next slide, Jared. The current evidence for the importance of community participation and why it's important for us to promote community participation and inclusion includes evidence that people who experience psychiatric disabilities would participate. There's ample evidence indicating that 70% of people with serious mental illnesses, schizophrenia spectrum disorders, bipolar disorder, and major depression consistently say that they'd like to work. Individuals are very interested in going back to school. People are interested in being engaged in religious and spiritual activities, just like everyone else. Our surveys consistently show that 80% of people say that being engaged in religious or spiritual activities is important to them, yet only 60%, but 60% of those individuals also say that they don't do it as much as they would like to. So there's clear evidence that people want to participate more. There's evidence that people could participate. We have lots of research in the field in supported housing, supported employment, some in supported education, and some in peer support, indicating that people want to participate and can participate in many of these dimensions of community integration. And finally, we have ample evidence that people should participate. Historically, there was a feeling that employment, for example, is stressful for people, that stress would lead to an exacerbation of symptoms, that an exacerbation of symptoms would lead to crisis, and the crisis would lead to rehospitalization. Therefore, there was a thought among some of our colleagues that promoting employment, for example, should be discouraged because it's too stressful for people. The research in all of these domains of community integration suggests otherwise. There's ample evidence suggesting that people who work have fewer symptoms, are hospitalized less, feel better about themselves, have higher quality of life. People who are going to school, same kinds of outcomes. People engaged in people who are married and have a serious mental illness or have intimate relationships with other people. The research actually suggests that that's a positive thing in people's lives. Being a parent with a serious mental illness, if you want to be a parent, is a positive thing in people's lives. So we have ample evidence that people should participate, and this has positive health benefits in their lives. And finally, the last bit of evidence, and it's not evidence like the other data that I was talking about, but community integration, again, is a right for people, and that by itself should be a major reason why we decide to promote it. Next slide. So, as Bill mentioned, the goals of this webinar are to review 10 areas where states, counties, agencies, and providers can take steps to promote community inclusion and really to help you jumpstart community inclusion initiatives. So let me turn it over to my colleague, Rick Barron.
Thank you, Mark. Jared, could we have the next slide, please? Hi, I'm Rick Barron. I wanted to start out with a quick acknowledgement that promoting community inclusion isn't really all that easy. It's a tough task, and it requires a level of persistence and clarity of vision that I think you'll find will serve you well. It's not easy because there are multiple challenges. We feel one of those challenges is certainly attitudinal, not only among staff members and community members, but among consumers and families themselves who have gotten used to building their lives around their engagement with mental health providers rather than around the rest of the community. It requires meeting the challenges of developing a better skill base for direct service staff in particular and their supervisors so that they know how to support people in engaging with the community and not merely try to meet their needs within the context of a provider agency. And one of the other significant challenges certainly is the financial challenge of finding ways to fund those community inclusion activities we'll be talking about is going to require some ingenuity and like these other challenges, our feeling is that these challenges can be met. It's necessary to begin moving toward this new generation of community inclusion services in our systems. Frankly, we don't yet have a roadmap. We're not here to tell you first do this and then do that, or use these forms and analyze this data. Focus on this fidelity scale of how your programs should be rebuilt. But we do have a range of strategies for state and county mental health systems, for community mental health centers, psychiatric rehabilitation programs, and other provider agencies, including consumer-run groups that we know have been successful because we've been working with agencies like that all across the country who have begun to take one initiative or another to move community inclusion forward. And so we're going to recommend them to you today, mostly because the really important thing for many of you, I think, is at the very least to get started in one or more of these initiatives. Jared, the next slide, please. So we're going to start with the notion of developing a community inclusion-related mission statement. Jared, next one, if you will. Mission statements are useful and have been used in the past productively. They've helped systems and providers shift from a focus only on providing safety and stability in their missions to more active goals. They've played a key role in moving the recovery movement forward. Almost every agency, every state, and every county has redefined itself with greater or lesser accuracy, to be honest, as a recovery-oriented system. But there's movement there. And many agencies have begun even to focus on competitive employment outcomes as part of their mission. What we're suggesting here is tweaking or revising mission statements to reflect, I guess, definable outcomes that focus on this emerging new generation of services that emphasize community inclusion, because redefining that mission statement can lead in many directions. It can lead to a review of policies. What policies do we have in our agency or our county that inhibit or support community inclusion? It can lead to a reconsideration of current programs. Which of our programs inhibit or support inclusion? And it can shift practices at the direct service level. How do we move people forward and not hold them back? And as well, a review of the mission statement can focus a new set of discussions with funders. We've had a couple of experiences in this regard. We're currently working with Mental Health America and the Association of Managed Behavioral Healthcare Organizations to develop a new mission statement for individual managed care entities that they can use to revise their contracts with state and county contractors who want them to play a key role in the delivery of services. And it can play a role in revising the contracts the managed behavioral care agencies sign with provider agencies in their communities. How do they define the services to be provided? How do they measure outcomes? How do they reconfigure staff roles? And we are hopeful in the years ahead we'll see a major movement toward redefining what it is even managed behavioral healthcare agencies are designed to do. The other example comes from the Pioneer Center, an example we'll talk about several times, I think, today. This is a multi-service human services agency just north of Chicago in McHenry, Illinois, where they've been developing a community inclusion approach that is built around a revised mission statement. They have a large mental health and IDD population. They focus so far on the mental health population and trying to shift from generations of providing safety and security as their major outcomes to engagement in community activities. And their revised mission statement has led to a top-to-bottom commitment from the executive director of the agency to the chief financial officer of the agency, all the way through the agency to supervisors, direct service staff, and peer specialists. They've done agency-wide training to clarify what this revised mission statement means, and they've begun to have discussions with every consumer in that agency coming in about the fact that their goal now for them is to help them define what kinds of activities in the community they want to engage in and how they can get there, and what role the Pioneer Center can play in supporting them. And soon they're going to be reviewing that mission statement with members of the community to clarify what this change means for the community. Jared, could we have the next slide? But we also want to talk about strengthening stakeholder commitment as a second strategy, because frankly, a mission statement is only as good, I think, as the commitment is real from a variety of stakeholders. Jared, next slide. You really need to build a broad commitment across the entities with which you deal to make this real. Certainly board members of your agency, where we can begin to talk with them about this shift in perspective, with consumers and families, with direct service staff and supervisors, and with community organizations, but also building commitment with funders, both public funders, Medicaid and state dollars, but also private philanthropic contributions about what it is you intend to do with these dollars, where you intend to go, what your goals are. It's difficult to do this. I acknowledge that. There's a mixture of education, of training, of providing them with materials. Your agency has to be prepared to listen and learn. Sometimes you have to take a step back and recognize there are some sacred cows. I was once dealing with a county program in the northern part of Pennsylvania where everybody, particularly consumers, refused to give up the Wednesday night bingo and social hour in favor of what we were suggesting, which is greater engagement in those kinds of activities in the community. So we lost that battle, but I think we won the larger battle of getting them to think about what alternative kinds of social engagements they could support for the people they serve. And of course, it involves beginning to define as part of this educational process your local champions. Who are the people who are really going to take this project and move it forward? We were working in Montgomery County, just north of Philadelphia, a few years ago, and were asked by the county to put together a fairly broad planning group to talk about community inclusion. One of the things we did for them was a survey of service recipients, mental health service recipients in the community. The survey showed us two interesting things to reflect part of what Mark was talking about a moment ago. First was that almost everyone they were serving did go to church on Sunday morning, but that's all they did. Everybody was clear that they got up, they got dressed, they went to church, and they came home, and there was really no participation in Bible study groups or charitable activities or field trips sponsored by the church. They were just going and coming home and not really engaged in the religious life of the congregation. And so they began to develop a specialized strategy to work with religious leaders, one of which was the Mennonite Church. And as a result of that, one of the fellows who participated on the committee was talking about the fact that several people from a local residential program had been attending the church and being at least disruptive enough to concern the congregation. But with a little help from the committee, they sat down with a young adult group within the Mennonite Church. 3 people volunteered, each one of them to call one of the people from the group home who were attending services, offer to meet them, welcome them into the congregation, meet them beforehand, sit with them during services, and introduce them to their friends in the social hour afterward. And that pretty much solved the problem. And so getting involved with a broad group of people who can address these issues is important. The other thing we found is that many of the consumers wanted to volunteer in the community, and this group put together an area-wide volunteer committee that searched out local community organizations for their needs and then began to meet those needs with people from the mental health agencies. And that worked out very well as well. Both initiatives reached widely across both the mental health community and community stakeholders, which leads to a third kind of strategy. Jared, could we go to the next slide? Which focuses on developing welcoming communities. There are really 2 issues here, we think. One is working with community groups to make them aware of and supportive of and actively participating in community inclusion initiatives. And the second is to work with consumers so that they are prepared to meet their responsibilities to their engagement in the community. Jared, the next slide. With regard to working with community organizations, part of it is understanding what sorts of resources exist in your community, learning what that participation demands, helping individuals, service recipients make their own decisions about how much they want to disclose as they get engaged in these organizations, and providing necessary support both to the consumer and to the community organization. We have found in general that community organizations are not that hot about the idea of starting specialized programs for a group of clients, but they are much more amenable to the notion of 1 or 2 people or 3 people over a year or 2 who want to participate in a particular activity, attend a church, join a baseball league, participate in a knitting educational program, and make the time and take the initiative to welcome them in. We dealt with a group in Greenville, Pennsylvania, some years ago who were beginning to try to respond to consumer interests in employment and realized that the mental health agencies did not have anywhere near the range of educational and training programs that they needed to really help consumers get into the kinds of jobs they were interested in. And so we suggested to them that they work together to identify what existed in the community. And within a month, excuse me, they'd come back with 60 different training programs within this small community. GED programs, vocational technical programs in high schools, community college programs, career colleges, 4-year programs, just a huge array of training opportunities for people who wanted to go back to work. And once having defined that, then the agencies had to figure out how were they going to support people in participating in them, and how did they approach those community agencies. But the second part really is that issue of supporting people. How do we prepare clients, the consumers of our agencies, for community participation when they've for so long spent an enormous amount of time in what I often refer to as the overly warm embrace of the mental health system? If you turn to our website, tucollaborative.org, you'll find documents that you can use to help people anticipate what college is going to be like, what it's like to re-enter employment, what it is like to be a parent, if you yourself have a mental illness, what risks you need to be prepared for. Please take a look at that website, and we'll be happy to talk to you about moving those forward. All of these offer ways we've seen work. This is just the first 3 initiatives about jumpstarting local community inclusion activities, and I'm going to turn the rest over to Bill Burns-Lynch.
Great, thanks, Rick. So first, I want to talk some about redefining staff roles, and Jared, you can move the slide. So when we look at jumpstarting community inclusion, one of 2 things has to happen, we think, in terms of redefining staff roles. The first is that existing staff need to have their roles and job descriptions redefined. Existing staff time needs to be redirected from a focus on in-house activities, for example, groups, classes, and individual meetings in the program office, to more time spent in the community focused on supporting individuals to connect with the non-mental health community organizations and activities that are of interest to them. Or secondly, we need to create specialized positions, community inclusion specialists, if you will, whose job it is to work one-on-one with individuals in the community, connecting our participants with the non-mental health community organizations' activities that interest them. And a critical part of this is to provide the necessary training and supervision for staff as they shift their responsibilities, and to really hold them accountable for delivering community inclusion activities versus agency and program-based individual or group activities. As an example, we're working with a supported housing program here in Philadelphia, where we're helping them to more actively build community inclusion into the role of their certified peer support staff. The housing program uses a team approach that employs mobile psych rehab workers and certified peer specialists to deliver services. So the task really we found is twofold. Clearly define the distinction in support roles between mobile psych rehab and peer support, and then clearly define the CPS role as a community inclusion specialist. As we've been paying attention to this transition, we're working with supervisory staff and trying to develop fidelity instruments to support the community inclusion work, and also to hold everyone involved accountable to the paradigm shift. Next slide, Jared. Next, I want to talk about the use of peer specialists, and you can move the slide for us. Another strategy to jumpstart community inclusion initiatives is to increase peer specialist involvement in community inclusion work. So in Pennsylvania, for example, and I think in many other states, CPS services are supported via Medicaid billing. As we work with other states and providers around developing peer specialist positions, we still hear and see a good bit of confusion about the role peer specialists can play in the community mental health system. We think community inclusion work is a great natural fit for peer specialists. Peers involved in this work can uniquely draw upon, obviously, their lived experience, their participation in the real world, their understanding of the importance in their own recovery of community participation, their passion and their knowledge about resources in the community, and their own developed strategies to accomplish their community participation interests and goals. But again, we find that peers need to be trained and supervised to do this work and to deliver effective community inclusion supports so as not to simply replicate what others in the system do, or for that matter, what others have done with them while they receive services in the system. A couple of examples here, if you could go back, Jared. There you go, thanks. So we've been involved with a number of projects that have focused on increasing the use of peer specialists and also clearly defining their roles and the tasks associated with their support services. We've worked here in Pennsylvania to identify the ways in which peer specialists can support individuals pursuing employment goals, something that Rick mentioned. It's important to note here that competitive employment goals are a central aspect of community inclusion for individuals with mental health conditions. There's a white paper available on our website that explores the types of activities that peers can support that are, in fact, reimbursable through Medicaid dollars. Additionally, the work that we were doing in that area supported the development of 2 nationally available training programs for peer specialists focused on supporting employment goals. A second example, we're currently working with the Commonwealth of Pennsylvania and a leading peer organization in the state on increasing the use of peer specialists in the delivery of crisis services across the state. That work includes identifying and developing the roles that peers can play working in programs delivering traditional and alternative crisis and emergency diversion services, as well as the development of a training curriculum to support the development of knowledge and skills necessary to do this important work. Our focus in this work really has been to help ensure that more people receive crisis services that are community-based and focused on keeping them within the community settings in which they live and participate. And next slide, please, Jared. The last strategy that I want to talk about is to talk some about funding, and you can forward the slide. So funding always comes up as an issue when we consult with organizations and providers. We hear a variety of concerns from things like we don't have the financial resources, or our funders won't pay for that. There's no new money in the system for that. But it's clear that this work is being done in a number of places around the country, and states and counties and individual service providers are finding ways to move forward and shift funding in this direction. I'll talk very briefly here about philanthropic funding, Medicaid funding, and behavioral managed care reinvestment dollars. Rick has already talked some about our work out in McHenry, Illinois with the Pioneer Center for Human Services. To give you a little bit more background, a couple of years back they received a phone call from the mother of a long-term program participant thanking them for the provision of almost 20 years of services to her son. But she found herself left with 2 important questions. One, why is he still going there? And what can be done to help him and others live and participate more fully in the life of the community? Fortuitously, I guess, she then offered a substantial financial donation to the organization to develop something different. After some consultation with us here at the Collaborative, we helped them shape a new community inclusion program that hired and trained 8 community inclusion specialists to work with individuals to identify and pursue their community participation goals. We should probably note that the first idea was to build a gym so that people could come to the mental health center and actively participate in the gym, which you are probably getting the idea kind of goes counter to our thinking in terms of community inclusion services. So initially these positions were funded through this donation, but soon the center realized they were able to bill for these community inclusion services through Medicaid, and now that's how these positions are maintained financially. Additionally, the donation was utilized to set up a scholarship fund to which program participants were able to apply to support their community participation goals. They could receive funds to join a gym, access transportation, take a college course, start a business, etc. Some creative use of the funding there. A second example of creative funding is a self-directed care project that we've been working with for a number of years now. The program looked at how much money had been spent on average over the past 2 years for participants' mental health care. Individuals then worked with certified peer specialists to identify their community participation goals and how they wanted to spend that money in the upcoming year to support those goals. So what happened, participants could spend their money on traditional mental health services if they wanted, things like case management or medication consultation, or on other non-traditional things like a gym membership in the community, a personal trainer, or tuition to take a class. As I mentioned just a bit ago, CPS services are billable through Medicaid in Pennsylvania, and that's how staff time was paid in this program. Additionally, the traditional mental health services that individuals wanted to access were paid for through the behavioral health managed care organization who held the contract in that county, and the non-traditional activities that supported their community participation goals were paid for by the county mental health authority through use of their reinvestment dollars. So you can see there are a number of ways to creatively use and blend funding to move programs in this direction of community inclusion and increase the delivery of services that really do support individuals' self-directed community participation interests. And with that, I'm going to hand things off to our third presenter, Gretchen, who will continue with the next two strategies.
Hello, everyone. Some of the things that I'm going to talk about, particularly as they relate to training, you may hear that some of the themes that we've talked on or touched on throughout the presentation are going to be brought up again, and that I think is a very natural flow because you set these things in place, but if you don't train individuals to implement those ideas that you have or those mission statements that you've developed, then it doesn't really go anywhere. So Jared, if you could move forward. One of the things that you really want to do is within your mission statement and within that defined role of community inclusion is to operationalize what community inclusion looks like. Train staff on a common definition and really integrate that definition across the agency. Oftentimes when we talk with providers, they may cite instances where they're supporting individuals in the community to participate with the mental health center. So often the example I use is the community outing or the bowling trip where everyone goes together. But it's not really truly community inclusion or participation. The goal really should be independent participation and not chaperone trips, which means that everyone working with consumers should develop strategies to support independent participation. And that may mean that if there are those specialized roles, those community inclusion specialists, then clearly they have a distinct training that says this is how I do those things. But it shouldn't be just that person's job. It's really everyone's job to integrate and promote community inclusion. So there needs to be there needs to be trainings that implement those or apply that definition and that training to each of those roles and each of those job descriptions so that everyone really knows how to do it. And then provide the opportunities for people to practice it within the trainings or within staff meetings. provide opportunities for role-playing or peer-to-peer mentoring so people can talk through some of the struggles that they have, because this really is a shift in how services are delivered and how people have traditionally seen their roles. And then once staff beyond this training, it's really important to just follow it up and not just have this one and done training, but beyond that training of staff, community inclusion needs to really be integrated into all of the treatment team meetings. And so there needs to be a full plan, and training doesn't just happen once, it's something that comes up consistently. And so have opportunities for staff to bring in case studies where they're sharing, success stories where they've seen consumers move from lower levels of participation to higher levels, where they can talk about what it was that helped them to get to that point, or talk about things where they might be struggling and they've observed specific barriers, which can be an opportunity for treatment team members to really talk about the different things that have been strategies that they might use to really increase community participation. That way that the team remains focused on the goal of independent participation, and it's not that community participation is not just something that they learned about during a staff in-service. And Jared, if you could go to the next slide, I can talk about some of the examples that we've been involved with. You've heard, I'm sure, about the Pioneer Center, which is actually what I'm going to talk about again. But this is really an example of some of the trainings that we've done with other agencies across the country as well. But really, we've been able to go in and look at, well, what are the services that you're currently offering? And are there ways that you can either need to create a new role that's specifically to community inclusion, or how can you integrate this into the trainings of all of your staff, from the high-level management to the person that greets, sits at the front desks and greets people. Everybody really needs to have an idea of what this community inclusion is about and how they can help support it. And really have the dedication and the time to do this intensive on-site training where everyone is trained on the same definition. They're given strategies to really think through what their role looks like in terms of supporting community inclusion, and then not just stopping at that, but providing opportunities for ongoing case review. Rick and I have done a number of these where we're actually working with a group in Wisconsin where they'll send us a de-identified case study where we'll look at that and we'll be able to talk through some of the successes and provide some ongoing support about what it looks like they're doing really well, and maybe some brainstorms and strategies where people can better develop their supports to really help those consumers move from isolated participation or engagement strictly in the mental health center to really engaging independently in the community. And this strategy, by addressing the training consistently and across all staff members, really helps to create a unity and helps people define their own staff roles in terms of community participation as well. Jared, if you could go to the next slide. The next thing that I wanted to talk about is looking at your program design and identifying those mainstream resources. And Jared, move forward, please. This seems fairly obvious when we're talking about community inclusion and participation, but it's important to really know what resources are available within the community that you live in, but also in the community where your participants are residing, because sometimes those may not be exactly the same. And so this, it's not just, well, I know that we have a library, but understanding the full level of resources that are offered by that resource. Do they have computer classes for adults? Do they have yoga classes? What are the transportation resources that exist that consumers could access so that they can independently get to the library or get to the YMCA? And really having a good and broad understanding of the breadth of resources that are available. And this is really important for a couple different reasons. First, and obviously, what's out there and can help refer individuals to those resources. And second, you may also be able to identify gaps that exist so that you can begin to be an advocate for the development of those resources within the community. You can also start to think about, well, we offer these activities in the mental health center. We provide computer training, so why do we need to understand what's available within the community? But the goal in understanding what resources are out there is so that you can stop offering those things in-house and really look to support individuals to access them independently. And the truth of the matter is that you're not going to find everything that's out there, but what you can do is that as consumers identify those unique community participation goals, you now have a better understanding of where things exist in the community, and you can support the people that you're working with to help find where those resources might be. And one of the examples, Jared, if you could move forward, is an ongoing intervention study we have right now is independence through community access and navigation. And one of the key things that we did within that study is that we developed the play manual, or the Philadelphia Leisure Activities in You, which is also available on our website. And this manual lists a number of domains of recreation and leisure activities that are accessible in the Philadelphia area. It looks at costs, so or free or affordable activities. They're broken down by whether or not they're on our local transportation route, so that we're able to talk with participants and integrate it into the assessment, where participants can say that they're interested in playing a sport, and we can refer them to the manual to say, hey, there's these resources that are available. It also allows us to understand where those things are, so that if the level of support to facilitate that independent participation is that they need someone to initially co-participate with them, we know where those resources are and what it takes for us as staff to support them as well. One of the things that we found, and we didn't find everything, there's an example where a consumer was interested in hip-hop dance, and we didn't either think of it or didn't identify those resources beforehand. But because we had a pretty good understanding of how to find some of the things that existed in the community, we were able to work with him and to identify where those resources might be, learn how to use the computer at the library so that he could start to look up some of those resources in the community as well. And I am going to turn it back over to Mark Felder.
Great. Thank you, Gretchen. I'm going to cover the last two areas fairly briefly and then turn it back over to Bill in a second. So I'm covering the identifying and utilizing community inclusion technology. And one of the things that our center has really done a lot of work in is to identify the technologies that already exist to promote community participation of individuals who experience significant mental health issues. The first are a set of steps or technologies that have really been taken out of supported housing, employment, and education interventions. These are a set of technologies that include things like helping the person engage in whatever area of participation they want to participate in right away, not going through necessarily specific training programs or technology programs or pre-employment or pre-education programs, but really getting people right into it right away, that the participation is a choice. We want people to participate in normalized settings, and I think we've talked about that before in this webinar. So there are a whole set of technologies that already exist, and to really expand them or generalize them outside of just housing, employment, and education into leisure recreation, like Gretchen has done, promoting religion and spirituality, promoting family and parenting relationships, all of these kinds of things are technologies that exist. Peer support is a technology that exists. Promotion of natural supports and natural social support, like friends, family members, really integrating them as a technology for promoting community inclusion. Accessing mainstream resources is a technology that we discussed earlier. Circles of support, which is a notion of pulling people together that are important to an individual to support that person in going back to school, in dating relationships, in going to a church, synagogue, or mosque. That's a technology. And finally, we have strategies for addressing poverty and discrimination and transportation issues that are really critical for promoting community participation. Some of the next slide, Jared. Some of the examples of this, we mentioned our website before. Here's the link to our website where we list a number of resources that are available that really describe some of these technologies and strategies that can be used for promoting community participation. They provide a lot of details and examples, but we're definitely available to speak with you further about how to utilize these. We have a number of manuals and materials that are in development as well. We also wanted to briefly mention that we also describe technologies, especially knowledge, in the College of Recovery and Community Inclusion, which is an online curriculum that we've developed in partnership with Elsevier, the publisher, and the University of Minnesota that really provides some knowledge and additional information about these technologies. And we'd be happy to talk with you somewhere down the line about what this College of Recovery and Community Inclusion is all about. Next slide. The last thing I'll briefly mention is gathering data on community participation. Next slide, Jared. Why gather data? We've worked with a number of organizations around gathering data for needs assessment, where agencies or programs want to know to what extent people are doing what they want to do in their lives. How much are they participating? What's important to them? Are they doing as much as they'd like? We've worked with agencies and programs to use these types of data to design new programs or alter current programs. We've worked with organizations to use these data around outcomes monitoring. And lastly, people gather data for marketing purposes, really communicating to funders and policymakers the types of impacts that you're having in promoting community participation and community inclusion. Some examples of this is we've worked in Bucks County, where a program called Voice and Vision has used our Temple University community participation measure to really raise awareness about the extent to which people in Bucks County are currently doing what they want to do. And this has really had an impact on policies and programs that are offered in Bucks County. The next example, 17, we've used it with the Veterans Empowerment Center at the Philadelphia VA. This is a program that I helped get started a number of years ago. And the Temple University Community Participation Measure is used to identify veteran goals for around community inclusion and really support that veteran in achieving community inclusion. And the last example, and we've talked about the Pioneer Center a number of times, they've been just a wonderful partner with us. They've used the Temple University Community Participation Measure to assess outcomes and how they're doing in terms of promoting community participation. Next slide, Jared. So I'm going to turn it over to Bill Burns-Lynch to bring us home.
All right, great. Thanks, Mark. So that, I think, concludes what we've prepared for today, but it really looks like we're out of time for questions at this point. We apologize for this, and we hope you get a sense of the excitement that we have here at the Collaborative around these initiatives, and perhaps we were just a tad overzealous in wanting to present as many examples as we could to you so that you could really hear the message that these kinds of initiatives are possible and really do foster change within organizations. So before we wrap up, I just want to take a second to say that as Mark and I think Rick said, we are happy to continue this conversation with you, and contact information is available on the last slide. You can also connect with us through our website at tucollaborative.org. If you have a question that you wanted to ask today, feel free to send us an email, and we will do our best to get back to you quickly with a response. Looks like Jared's already moved the slide there. So I would really, from all of us here at the Collaborative, I want to give a special thank you to Jared, who's behind the scenes there, organizing all the logistical support for us. So thank you, Jared. And again, I want to thank all of you for participating in today's webinar. And encourage you to even identify, just one or two strategies that were presented here today and begin to develop action plans to move community inclusion forward at your agency and organization. Again, we are here to help. We would love to hear from you, and we invite you to reach out to us here at the Collaborative. Be on the lookout for an email next week with a link to the webinar recording and a link to the evaluation survey. Thanks again, take good care, and we hope to hear from you and see you out there participating in the community. Thanks.